Hello, everyone. Welcome back to Science in the Age of COVID-19. We are very happy to have you all with us here today. Our guest for today is Dr. Michael Mina. He's an assistant professor of epidemiology at the Harvard T.H. School of Public Health and a member of the school's Center for Communicable Disease Dynamics. He's an assistant professor of immunology and infectious disease at the Harvard T.H. School of Public Health and an associate medical director in clinical microbiology in the Department of Pathology at the Brigham and Women's Hospital at Harvard Medical School. Dr. Mina uses a combination of mathematical and epidemiological models to understand the pattern underlying infectious disease. He has been at the front line of the COVID-19 pandemic, has been instrumental in establishing high-throughput testing in different institutes. And for those of you following his work, you probably know that he's a major advocate of rapid antigen testing. Guess we'll hear a lot about that today. And learning lessons from the COVID-19 pandemic, he's working with a group of colleagues to develop a global immunological observatory, which is a network of laboratories to monitor emerging pathogens so that we are better prepared for future pandemics. Dr. Mina, thank you for joining us today, and we look forward to your talk.
Hey, well, thank you so much. I'm very happy to be here. So today I want to talk about COVID-19 testing and with an emphasis at this point in the pandemic on the intersection of public health and policy and regulation and where in the midst of an emerging crisis, these might not all always align. So I'm going to be talking largely about testing for the virus and how we can actually use it, not just as a medical tool, but as a strategy to help us get out of this pandemic and ideally to learn lessons for the next ones that are undoubtedly going to arise. I would suggest that, thus far, we really have not devised any actual strategy around one of the most crucial tools that we have to fight a pandemic like this, which is knowing who's positive and who's negative and testing. To do that, there has been almost no strategy that's really been put forth in any real way, which continues to be both surprising and frustrating. And I hope that this provides some insight into what a strategy could look like and how we might think about testing outside of the context of medicine. I get a lot of questions about, we have vaccines coming out and testing is it necessary? Do we even need to test for the virus? I would like to say no, but I also want to emphasize that graphs like this exist and data like this exist. We have seen a massive reduction in cases in the last month or so, and this has, of course, led to exuberance and people feeling like this virus is sort of on its way out. But what we need to be very aware of is that this virus it's a very seasonal virus. Last summer, when cases were pretty low in much of the country, some of us were saying we have to do everything we can to prepare for the fall and winter. It's probably going to be a devastating event. Unfortunately, I would say that advice was not completely heeded, and of course we had massive upswing in cases. But we see coronaviruses come and go every single year. And so what I'm showing in the green here on each of these curves, that's beta coronaviruses. These are the viruses that are closest in nature to SARS-CoV-2. And what we can see is every year they spike in October, November, December, and then they drop precipitously in the beginning of the year in February or so. And so while we are seeing a lull in cases at the moment, and what I have on the right here is just something that I find interesting anyway. I've just superimposed the 10-year seasonal average of HKU and NOC43, the other beta coronaviruses, on top of the New York Times data for the United States for cases. And, so this to me just suggests that while there's been a lot of questions around, is this a seasonal forcing effect that's dropping cases, or is it something else? Is it purely behavioral? I don't personally feel that this is a behavioral shift that we're seeing that's really causing the loss in cases. I would say that this is probably seasonal effects combined with herd immunity to a certain extent for the latter. But ultimately, the purpose of this is to show that we need to be prepared for upswings that will likely occur again in the fall. People who are getting vaccinated today are going to, unfortunately, especially the elderly individuals, their immunity will probably wane considerably by the time the fall comes around. Ideally, we won't have severe disease, but I think that to keep the economy open, we're going to have all of our ducks in a row and all of our tools in place. And testing is a major component of that. So while all of our regulatory and our entire regulatory environment has largely focused on personal health, and that's pretty much how we have continued to consider testing throughout this pandemic. It's been considered to be a prescription test for the most part for symptomatic people or at-risk people. Despite it being used, I think most people who have been tested generally are getting tested without symptoms, not for personal health. Yet our entire regulatory landscape is focused solely on diagnostic medicine. Intuitively, in the midst of a pandemic, we recognize that what we actually want is screening testing. We want to just know, are we infectious? These are not tests that should require a physician's input, nor should they require sort of the robust type of test that is used in a hospital. They can be, that type of screening testing can be done with a different type of test that prioritizes different attributes, which I'll go into. We also have surveillance testing, asymptomatic testing, wastewater and surface testing. So there's all of these different types of testing. Nevertheless, our entire regulatory landscape has focused essentially only on medical testing. And so we've been trying to claw back a massive public health problem using a medical approach. And this is, in essence, why I think we have failed, so intensely failed, in terms of being able to slow spread through the use of testing, screening, and isolating. So this is taking a slightly different direction for the next couple of slides. What if we knew about COVID spreading in the US during February? Testing, the problems and woes that we've had with testing are not new to this pandemic, but could we have had a different system set up so that we could actually identify cases early in a pandemic, before we had any medical testing, before we even knew that the pandemic was on US soil, for example? What if we had this set up in February of 2020? We know now that in New York City, for example, by the time we started detecting cases, there were probably thousands and thousands of cases already circulating. We knew that it was already in California, Seattle, and of course, New York. Could we have had a system set up that would have identified cases early? And this is something that I've been working to essentially set up is, could we create in something like an immunological observatory, a weather system that could be an early warning system for new viruses? Had we been able to shut down New York City 1 week earlier, estimates suggest that we would have had, instead of around 17,000 deaths, around 3,000 deaths in New York City by the beginning of May. But the governor of New York was not able to shut down the city because there was no data yet to suggest that the city should be shut down. So this just begs for new systems and new approaches to allow us to have early warning systems to know where the virus is transmitting at any given time in the world, and ideally to identify new outbreaks before they get started, new novel pandemics before they spread globally. So this is an idea that myself and colleagues at Princeton, Brian Grenfell and Jess Metcalf, and some others have been trying to get set up for quite a few years now. Of course, this pandemic is accelerating some of our ability to do that. But the idea is to create a global immunological observatory, a platform that could work very similar to how the weather system works today. could we actually use testing and testing of convenience samples, whether it be blood samples that come in from blood donors, that come in from plasma donors, hospitalized samples. We throw out millions and millions and millions of samples around the world every single day for no good reason, except that those samples aren't useful. If we could capture samples or even create other sorts of programs where people are incentivized to just give a finger prick or give some saliva to be able to monitor people, we could start treating humans as weather buoys. And humans can start essentially serving as the weather buoys that provide the data to allow us to track pathogens with some strategy to be able to use testing. In this case, it would probably be immunological testing rather than viral testing. But we could start writing the rules of how viruses transmit. We could start getting early warning systems by coupling mathematics with immunology and with biology to really understand where viruses are, when they're most likely to hit. And perhaps one day we would be able to open up our iPhones and not have to get our child tested to know why they have a runny nose and are they safe to go to school? Do they have flu or do they have rhinovirus? But maybe we can open up our iPhones and type in our zip code and it says that there's a lot of rhinovirus around you. That's probably why your kid is sniffling and there is no COVID and hasn't been any flu for a year. And so you're probably a safe bet not to worry that your child has flu or COVID. That's a new approach to how we might be able to tackle and monitor pandemics and just seasonal endemics in a whole new way. And I think that we can set this up. It will take rigor and it will take a lot of determination. But I do believe that just like we set up the weather system that we have today, and now it's been a huge payoff. I think by any metric, it pays for itself. Doing the same thing for pathogens is certainly doable. And we would probably be thanking ourselves in 50 years if we have something like this actually set up. And now we're actually seeing that we have the tools to build this. This is work with Steve Ellich, who's an HHMI investigator. I was a postdoc in his lab, and since then I've been building out new tools that are somewhat based around some of the original tools that his lab had developed. This is a tool called VirScan, but now we have, the point of this slide is to show that we have profiling techniques that we're developing that can allow us to measure in just a single drop of saliva or a single drop of blood antibodies to a huge array of pathogens at a single epitope level. So what I'm showing here, every column is an individual, and every row is an antibody or is a different epitope. And where you see dark red, that means somebody has a lot of antibody to that particular epitope. Light red is a lower amount, and white is no antibody. So what you can see is that every individual, this is all for every individual, we use less than a microliter of serum to be able to get this data. And we run hundreds of thousands of antibody tests simultaneously for just a few dollars. What that means is now we actually have a platform to be able to identify people's exposure to different pathogens. And there's about 400 additional pathogens that I'm not showing. I'm only showing 4 here. We have a tool that can allow us in high throughput to be able to identify everything that somebody's been exposed to through their immunological imprint or footprint that they might leave that's existing in their bloodstream. So with just one drop, we could do this. And given the high resolution that we can get now, we could actually start envisioning a world where people truly can serve as buoys, where we can collect so much data from every single specimen that we can actually start understanding how all these different pathogens are working together, transmitting, what are the rules, how do they engage with each other and with humans, and how quickly do they spread. We then have to set up the logistics chains, of course, to be able to use these samples in some sort of robust way to actually make this weather system. But it's not just taking individual samples like this. What I'm showing are just individual cross sections. That's not particular, that can be very powerful if you get huge numbers, but what's much more powerful if you're really trying to look for early outbreak detection is to have the same people sampled over time. If you have the same people sampled over time, then you can know when people go from negative to positive on an antibody test. And you could say, okay, that person must have been exposed to RSV or influenza or whatever the pathogen might be. And if you do that enough times, then you can actually start understanding what the spread of a virus is. And so we had a problem because most of the samples that we get from blood banks or from hospitals are generally de-identified, meaning we can't identify them. We have no idea where the blood comes from. We just know that it's coming from somebody at a given zip code on a given day. But that essentially removes our ability to use longitudinal data to really improve the effectiveness of our surveillance programs. So we've been actually working on this problem. What we found is that we can actually take somebody's immunological profile and we can create anonymous biological fingerprints for individuals. Essentially, people's antibody profile is sufficiently stable that we can take their profile at any given point in time, and even a specimen that we get from that same individual years later, we might have no idea who the person is, but we would be able to link those two blood specimens to each other to say that they come from the same individual. And so what I'm showing here on the right is just an example of some different pathogens. We have a bunch of people, a bunch of different specimens that were sampled and tested using these profiling techniques, and the dot represents the titer of pathogen, titer of antibody against a given pathogen for a person in time. But what we found is that over even years, we're able to tether together some individuals' specimens and actually start creating longitudinal time series out of what are otherwise considered completely anonymous cross-sectional specimens. And this is important because many people who actually provide, who go and donate blood are repeat donors. So if we can actually start taking all of these repeat donors and tethering together their anonymous blood samples together so that we just know that this group of blood is coming from some random individual, we don't know who they are, but we know that they're from the same person over time. All of a sudden, we can start building some of the world's largest longitudinal data sets, not just for surveillance, but to understand immunological signatures and responses to pathogens and vaccines, and a huge plethora of different uses for getting such massive scale longitudinal data sets without actually having to recruit people to join into a study longitudinally, which is generally very, very expensive. So we've been developing these tools, and I would say combined, these tools are really starting to build a platform and a foundation for a true immunological observatory that could be long-lasting and global. So I'm going to change. I wanted to show this because I thought people on this call might be interested in this type of thinking. But I want to switch gears now and talk about viral testing for COVID, which was really the center of this talk. And so sensitivity has been sort of front page news. Everyone now has heard about the sensitivity of this test or that test. And it is the priority for testing for COVID, using a PCR test or an antigen test or whatever it might be, has been sensitivity. But this is a relic of treating every test like it's a medical test. If I'm a physician, when I see a patient, I want to be able to tell my patient that I'm giving them the best test possible. It's a one shot that I have with this patient, and I'm getting that sample. But that's not a public health way of thinking, and that's not a way to tackle a pandemic. When we're really trying to tackle a pandemic, we don't want to just focus on the sensitivity, assuming that we have a test, assuming that we have a sample. We want to focus on the sensitivity to catch infectious people out in the population, which is different than the analytical sensitivity. So the question is sensitivity the best characteristic to really focus on when we are thinking about testing? Or should we be really focusing on the frequency of tests and the speed to get results, maybe more so than the sensitivity? And are fast results and inexpensive tests worthwhile for tackling a pandemic, even if they are 100 times less analytically sensitive, for example, than a PCR? And so these tests exist now. While so much of the emphasis has thus far been on the PCR laboratory tests, we're now seeing a whole new era of testing become available. What I'm showing on the left are these are CRISPR-based tests, paper strip sort of rapid molecular tests that are actually on a paper strip. And then on the right are Binex Now card. That's an example of a rapid antigen test. These are tests that will detect the virus, but they don't have an amplification step. So they're not going to be quite as sensitive as a PCR test. But is that okay? Especially if they can be produced at a scale that far exceeds what we could ever possibly do if we focus on laboratory-based testing. If we could, for example, have everyone in the United States using a test twice a week, using a simple paper strip test twice a week, because they're only $2 a piece and they can be made in the tens of millions per day. Would that be a better way than just focusing on laboratory-based testing? And so to really understand this question, we have to kind of dive into the viral kinetics of this virus. While we've focused almost entirely on the limit of detection of PCR as our gold standard, that neglects to consider what is the frequency with which we can actually do PCR, what's the turnaround time. The reason this is important is because the virus, when it grows inside of somebody, it grows very fast. Once somebody exits the incubation period, when they're essentially first developing, when the virus is first starting to grow, essentially no test will find them. But then the moment somebody becomes positive on PCR, they're essentially raging upwards in terms of viral load. Within a day or two, maybe 3, they'll be at their peak viral load. And 99% of all of the virus that somebody has during an infection is going to happen just within a couple of days. People might be positive for 20 or 25 or 30 or 50 days, but almost all of the viral load is concentrated in this one little bubble. Just the tip of their viral kinetics, that's where almost all of their virus is. So if you're not catching virus during that window of time, you're effectively not really working to stop transmission. Of course, if you can catch it earlier, that's great. And that's where a molecular test might shine a bit more than an antigen test. But the point of this slide is to show that any of these tests, even the poorest quality of a COVID test, will detect people when they are at 1 billion viral copies per mil, for example, when they're actually transmitting. And so while we focus so much on the PCR limit of detection, for a pathogen, when our goal is to detect transmissible levels of virus, maybe we don't need that limit of detection. Maybe we just need, maybe our focus should be on actually ensuring that we're testing people frequently enough to actually catch them. And we can use lower limits of, or poorer limits of detection tests, as long as our goal is to detect infectious people and not to detect people 2 or 3 weeks out from their infection. So if you're not used to looking at logarithmic curves and CT values, the cycle threshold is the way that we evaluate a qPCR test. It's how many cycles do we have to run the qPCR instrument until a viral load becomes detectable, or before the RNA becomes detectable. And so we're amplifying it. So it's magnifying glass. This is how we're normally showing viral loads, which is essentially what I showed in this curve as well. But this is a log scale. Because we don't often switch between log and linear in our head, I just want to show this to really drive this point home, that these two curves are identical. One is on a linear scale on the bottom and one is on a log scale. So to even be able to see on the top graph, to even be able to see a CT value of 40 to a CT value of 35, we've had to essentially magnify or zoom in 1 million times in order to be able to identify and be able to visualize the lower part of that curve. So almost all of the viral load is truly captured in just this small little window, even though people are staying PCR positive for a very long time. And this has been confusing. It's been confusing to the CDC. It's been confusing to regulators. Essentially, this is something that is not usually thought about. How does the viral load really change over time? We don't have policy around it. And instead, the FDA has taken a stance where any test for COVID has to achieve the sensitivity of PCR, which could potentially detect people all the way out to day 25, for example, there, while then refusing to authorize certain tests that can do a very, very good job at detecting people in their transmissible window, with the fear that somebody might still be infectious at day 20, for example. And that's an unfounded concern in general. So the speed matters. It's not just the limit of detection of tests that we're concerned about. Really focusing on the speed of a test is just so crucial in how we think about combating a pandemic like this with testing. This is just an example of school-based entrance screening. We have two different scenarios on the top and on the bottom. They're identical scenarios, but the only thing that's changing is the type of test. We have 5 individuals walking into a building who are infectious, or into a school, whatever it might be. On the top, you have a 100% sensitive PCR test, but it has a 2-day lag time in terms of getting results. On the bottom, you have an 80% sensitive rapid test. It has a 15-minute or less than an hour turnaround time, but it's only 80% sensitive. Most people, if you give them the different options, they're going to say, I want the 100% sensitive test. And in fact, that's what our CDC currently says. That's what most regulators say. And it's just, for whatever reason, sensitivity has taken priority in people's minds. But this simple thought experiment gives us a very clear example of why just focusing on sensitivity and not speed is such a bad idea. If we take the upper scenario where we have 5 individuals walk into a school, they all get a PCR test, but they get a result 2 days later, and you're doing that on some frequent basis. You're going to have essentially 10 person days of people walking around school infectious. What that means is you're going to ultimately find them all at day 3, because you'll get the PCR results back, say, 48 hours later. But in the meantime, they have potentially infected 5 or 8 people, and potentially sending 20 or 30 people to quarantine. On average, in schools and universities, we have 6 to 8 people quarantined per infected individual. That's almost a year of person time in quarantine amongst those people. And you get 8 other people infected. On the other hand, if you use your 80% sensitive rapid test, on day 1, you are immediately able to identify 4 of those 5 people, pull them out of circulation before they infect others. The 1 person squeaks by because they were part of the 20% not recognized, infects maybe 1 or 2 additional people based on R of 1 to 2, and sends a number of people to quarantine, but maybe 5 or 7 or so. So with the lower sensitivity test, it was the speed that really allowed the lower sensitivity test to shine here from a public health perspective. As a physician, you might want to ensure that whenever you get the result, that it is the most accurate. But as a public health practitioner, that is just simply the wrong way to think about testing. Unfortunately, it's where all of our regulation, 100% of our regulation, has been focused, with zero focus or even question about the frequency with which a test might be able to be deployed, the speed with which it might be able to return results. So if we look at more of a population level, this is work that we published in Science Advances earlier this year, or late last year, I forget when. It's been out of preprint for almost a year now. But this was to demonstrate the frequency of testing and what is the role of frequent testing versus the sensitivity metrics of these tests. And essentially what this slide is just showing, this is based on agent-based models of outbreaks. Relative to the no test scenario, if we were testing daily or every 3 days, it really does not matter if you're using a high sensitivity or low sensitivity test. If you're testing multiple times per week, you are very likely to stop any outbreak before it even gets started. We could be doing this in the United States. We could be doing this all across in businesses and schools, all across the world, really. We could have frequent tests available, these simple paper strip tests, to essentially curb outbreaks, to stop them from spreading and get R way below 1 in order to get them to cease. When we start testing every week or every 14 days, we really start to lose the benefit, any real benefit of reducing transmission through testing. Most people get tested on the average time between tests in the United States is on the order of 6 months or so. Most people just simply aren't getting tested, in fact. Amongst those getting tested, most are not doing it even every 14 days, but even that does not really provide much of a benefit compared to sort of multiple times per week. And if we look at the turnaround time more formally here, we can see that even amongst those different bins, we have the two different types of test, high sensitivity and low sensitivity test. We have the different frequency bins, but even at high frequency, the moment you start sending out to a lab, so if you are testing every 3 days, but you're getting your results back 2 days later, then you start to really lose the benefit of your testing program. You're just not catching people in insufficient time to stop them from transmitting to others. So we have to really focus on tests that are giving, if our goal is to stop outbreaks and stop transmission, we want to focus on tests that are going to provide 24-hour turnaround, or much better still, is focus on rapid tests, rapid antigen, and now new rapid molecular tests, which are coming about. This is essentially what a picture of an outbreak might look like if we were to start using rapid screening programs. If we were to have an outbreak that's sort of raging upwards and we have 4% prevalence in the population, which is a very high prevalence at any given point in time, and we start a rapid testing program, if we were to test, if we had half of a whole community just completely refuse to test, they just flat out refuse to listen to the results. They don't care about the results. Maybe they're using the test, but they're throwing them away. And then we have 10% of the tests just completely fail. We could still, just by testing those 40% that are left, by doing that every 3 days, we can turn the corner of an outbreak that's scaling upwards very, very quickly. And within a matter of weeks, we would be able to get R very low, far below 1, and have the outbreak start to come under control. Within 2 months, you could have massive declines in the cases relative to just continuing exponential increases. So this is an approach not just to prevent outbreaks from occurring in the first place, but you can also use testing and constant screening to empower people to know their status so that they can make informed decisions that will help them not transmit. And when we do that to enough of the population, it doesn't have to be perfect. We just have to get, for every 100 people who are infected, we have to get them not to infect 130 or 140 additional people. We just have to get those 100 people to infect 90 people. And if we can do that, if we can just get 100 people to go on and infect 90 people, then within 30 days or so, we have those 100 people turn into 50, versus if 100 people are infecting 130, then those 100 people turn into 500 people in 30 days. So we get a 90% reduction just by getting 100 people to infect 90. So it doesn't need to be a perfect screening program by any stretch to completely control outbreaks over a number of months. So while we have placed all of our priority on sensitivity, and the FDA is blocking many, many rapid tests because they're not quite as sensitive as a PCR test, and the CDC itself continues to publish poor data that suggests that rapid tests are not working, not recognizing that, unfortunately, they work very well to identify people in the infectious phase. We're putting all of this effort on sensitivity, and we're completely missing the forest for the trees in terms of dealing with a pandemic. And that is that it's the frequency with which we get people tested. It's the speed at which the tests return results that far, far outweigh the sensitivity metrics of a test when our goal is to stop transmission, versus using it as a tool to just diagnose people. So do these inexpensive tests work? I have one here. This is a rapid paper strip test. Inside of here is just a little strip of paper, like I showed earlier, with some monoclonal antibodies printed on it, and some different laminates. But essentially, they're made very cheaply. And what I'm showing here is results from a recent prospective study. Essentially, we were able to follow people in quarantine and PCR test them every day or two, sometimes every 3 days. And so we actually knew the ground truth of when people first turned PCR positive. And we were then able to evaluate what is the percent agreement or the sensitivity of these really inexpensive rapid tests compared to a PCR test. What we see is that although they don't work very well on day 0, many people still have low viral loads on day 0, as you can see on the top right. And again, this is CT scale, so this is logarithmic. But within a day, essentially, viral loads are sky high. Most people are at their peak viral load within a day or two of first turning PCR positive. At that point, these tests are essentially getting 100% sensitivity against the PCR. And then, of course, the sensitivity starts to fall away, but not because the test isn't working well, but because, as you can see on the top right here, people start to clear their virus. The real infectious period is in sort of days 1 through 6 or 7 or so. But a lot of those people are already clearing their virus by day 4 or 5, at which point the rapid tests start to decline in terms of their sensitivity, even though the PCR will still be at 100% sensitivity this whole period of time until around day 9, you start to see some people become negative. So these tests are working extremely well for their purpose, which is to identify in real time people who are infectious and need to be isolated, even if they don't work so well to identify people who were infectious days ago. So the fact that these tests do miss some of these people at the very first beginning stage means that I like to think of these as red light tests. These are tests that if you're negative, you continue to take all of your same precautions that you otherwise would. But if you're positive, then you isolate. So it's only a red light test. There is no green light associated with these tests, meaning they're not tickets to go and party. On the other hand, there's this whole new generation of tests. This is a test called the DETECT test. There's going to be a whole new generation of really inexpensive molecular tests that will detect you in those first couple of days. And so, and these are going to be inexpensive and highly scalable, whether they're LAMP tests like this or CRISPR-based tests. There's going to be a whole new assortment of different testing programs that are going to be made available. These new molecular tests, I think, are going to start achieving what I would call a green light test status. If you're truly negative before you go to work on a given day on one of these tests, I would say that that can start to allow business leaders to actually think about how to actually consider that people are generally, that you have created a somewhat of a bubble. Is it perfect? No, but it is a way to start to get communities back into some level of normalcy. If you can show that you've been negative on one of these molecular tests in the last 5 hours, the chances that you are transmitting, even if you have been exposed and infected days earlier, are extremely low for that day. It doesn't say anything about the next day, but it does say something about that period of time and probably for the next 5 or 8 hours, which is essentially the work day or the school day. So we could start seeing green light test use cases with some of these much more sensitive molecular tests coming about. So this is just to show there's been so much confusion about rapid antigen tests, and they haven't been authorized because the FDA has generally seen them as less sensitive. This is sort of everything I was just explaining, but using a very nice model. This is put together by a postdoc in my lab, James Hay. We're able to show what is the theoretical sensitivity of a test, of a public health test, if the purpose of that test is to identify infectious individuals when we compare it to PCR. And what I'm showing here, so we have simulations that we can run, but essentially just focus on the bottom graph on the bottom left here. This is the theoretical maximum sensitivity that an antigen test can have against PCR. And in this case, we're not even talking about antigen. We're just asking if we have a test that can detect you during 10 days of your PCR positive status, or if you're infectious during 10 days and you just want to have a test that will catch you during that infectious period, but then you remain positive for a longer period of time, say an additional 5 days, or in reality, it's probably more like you're positive, you're infectious maybe for 10 days, and then you're PCR positive for another 10 days. That's probably a very conservative estimate. You're probably actually only infectious for 7 days or so. But what this is showing is the expected sensitivity of a 100% sensitive infectiousness test compared to a PCR test. And so we can see in the middle line here, this is probably one of the more realistic curves, is A, the sensitivity changes over the period of the epidemic, and I could explain why, but I won't go into detail for that now. But essentially the theoretical maximum sensitivity that an antigen test should have against a PCR test, or that any test intended to detect infectiousness should have against a PCR test, is around 60%. And then it drops down as the epidemic continues on, depending on when you're recruiting people for your study, down to around 30%. That is the maximum sensitivity that these tests should have against PCR. On the other hand, the FDA mandates that these tests for asymptomatic people achieve an 80% sensitivity. So this is the regulation. But essentially what this data shows is that if you have a test, just the different clearance rates of live virus, of infectious virus compared to RNA that the PCR detects, means that the FDA is asking for an impossible thing. They're asking for an 80% sensitivity of an antigen test against PCR in a representative sample of asymptomatics. Meanwhile, the mathematical optimum, or the mathematical maximum, is somewhere around a 60% sensitivity, is all you could possibly expect, even for a test that is 100% sensitive to catch infectious people. So essentially the FDA and the regulatory landscape just simply haven't kept up to date with the science. And they continue to ask impossible asks, which is why we simply don't have any non-prescription asymptomatic use testing formally authorized by the FDA, except for one test called the Illum test, which the only way that you can achieve the 80% that the FDA is asking for is by either messing with your data or very, very selectively recruiting people who are not yet infectious, but probably will be soon, or who are not yet symptomatic, but probably do become symptomatic later. It's not the true representative sample set the FDA asks for. So this is just to drive home this message that when we're doing asymptomatic testing, most people, especially when cases are low, are going to have very, very, very low viral loads, meaning that most of them who are detected through PCR are going to be post-infectious, which is what's driving these metrics here, where we say only 30% of people should be, of PCR positive people should still be infectious. And this is a good example of it. This actual data, each violin plot here is a week in time in Massachusetts. And essentially what this is showing is that the vast majority of asymptomatic screening tests that we took in Massachusetts in June and July, when cases were at a lull, most of those people had exceedingly low viral loads with CT values above 35, meaning almost, essentially negative for virus, more or less, while only a small subset continued to have very high viral loads. So this data essentially suggests that most people who are detected as PCR positive, especially when cases are low, are no longer infectious, at least when we're using low frequency testing. The only way to actually catch people who are in that infectious window, these small bubbles of people with very high viral loads, is if you're doing frequent testing. And that's, of course, not what we've been doing in general in the population. And so we're just going to end up isolating the wrong people. We're going to isolate lots of people who are post-infectious and then contact trace the wrong contacts and waste millions and millions of dollars and have no real impact on the spread of the virus. So for a country like the US with 330 million people, if we could get 10 to 20 million rapid tests out per day, which we absolutely could with these simple paper strip kind of tests, we would actually be able to get herd effects at the community level and stop spread of the virus. We could keep false positives very, very low, which has been a concern for many, but in general, the false positive rate of some of these is less than 1 in 5,000. And we could, if we could have these kinds of tests in parallel with all of the other public health measures, including vaccines, I feel pretty strongly that we would be able to get ourselves back into full swing as an economy in the next couple of months and keep it there, even in the context of new cases emerging in the fall, we'd be able to keep outbreaks at bay without having to close down again. And this would also work in the case of mutant strains evading vaccine-derived immunity, which I'm very concerned about. It's another area of my laboratory, my research. Now, I do think that we will probably see immune escape from the vaccines, and we need contingency plans, and these kinds of tests are provide some of that. So while we have focused intensely on the sensitivity of testing during this pandemic, we have essentially missed the forest for the trees. We have a lot of tests that could be brought to market and brought out as public health tests. In this country, tens of millions of rapid tests are sitting delayed by our FDA, primarily because they don't meet the metrics that the FDA wants against PCR. But if our goal is to get a frequent testing program started, we should be able to use these tests, even if they're not as sensitive to detect non-infectious RNA. If they're very sensitive to detect people who are infectious and they give immediate results, they are much better tools for dealing with a pandemic. Unfortunately, our regulatory landscape has just not kept up, and we have not been able to get these tests out. And in the US, despite using very, very high sensitivity PCR laboratory tests, the more appropriate thing to consider is, what is our sensitivity for identifying infectious people? What's the sensitivity of the testing program to identify cases and pull them out of circulation? And for that, we're using very high sensitivity tests, but our overall sensitivity of our testing program is around 5% sensitive to catch people in time to actually act and isolate them and quarantine their contacts. So this should be the number that we are focused on during a pandemic. It should not be the analytical sensitivity of a test, but the sensitivity of a testing program. And unfortunately, this is entirely absent from our thinking still. So I'm going to stop there. I'm happy to take questions.
Well, Michael, that was extremely eye-opening. Okay, so audience, please remember to put your questions in the Q&A box, or you can raise your hand and we'll call on you. So Michael, I mean, so the U.S. healthcare system has a great number of deficits for facing problems like this. Are there other regions or organizations, or has anybody done a good job implementing rapid antigen test to take control of the situation?
Well, that's a great question. I'm wondering, is my video off? Did it just go off?
Yeah, something, yeah, we can't see you for some reason.
I wonder what happened. Well, I can either, it doesn't seem to be coming back on. I don't know why, but I can.
Here, let me see if I can turn it off and then turn it back. Okay.
Well.
Okay, that's really weird.
That is strange.
Matt, do you have any ideas how we can get his video back?
I would say in his camera icon in Zoom, just click that and make sure that it's selected the camera he was using.
It is.
It looks, yeah, it's not crossed out. It looks like it just stopped.
Huh. Can I exit and come right back in? Is that okay if I do that? If I take 20 seconds or 5 seconds?
That should be fine.
All right, I will exit. I have it copied.
So audience, take this time to get some questions in the box.
Raise your hand.
Yeah, raise your hand.
Very odd. It is not allowing me to show a video.
That is Really weird.
Let's see.
Michael, one last thing to check in that.
There we go.
Oh, hey.
I undid my my external monitor and sat back at my dining room table. All right, I'm back.
Yeah, so has any place taken your advice and done a bang up job of rapid lower sensitivity testing?
So the only real place that did it in a way that was commensurate with sort of that was really following this approach. Well, yes, I mean, the easy answer is it wasn't with rapid antigen testing per se, but so many of the campuses and universities in the Northeast have done this, and some have actually done it with rapid antigen testing as well. Those, to me, are the proof is there. These campuses, even when cases were raging in across the U.S., these campuses kept their campuses essentially free of COVID. It was like, university settings are potentially the petri dishes for this virus.
Yeah.
We saw places like Penn State, for example, not to pick on Penn State, but they didn't. They're such a big campus. They didn't have a frequent testing program set up, and they had outbreaks, and they just never controlled their outbreaks. They had huge fractions of their population infected. On the other hand, you look at Cornell, or you look at any number of institutions in the Northeast that used some of the testing programs that we set up at the Broad and other places. And these institutions ended up being little bubbles where there weren't really cases. If once an outbreak started, they were immediately exhausted and extinguished because we had such a high frequency of testing that we were able to identify people early. It doesn't mean cases never happened, but what didn't happen was outbreaks never persisted. And that should be the goal during a pandemic, is not to stop every single case, but to stop every single outbreak. So we have huge evidence bases for frequent testing that ultimately happened at university campuses. And that generally came from some of the early work we did in this pandemic to suggest that frequent rapid testing would go a long way. And that was actually using laboratory-based testing. We've seen some schools that use like the Binex now and some of these really rapid antigen cards, and they did even better. They were able to have a whole different set of tools where right during their contact tracing, they were able to just identify people and immediately test them and be able to find infectious people much more quickly. And now we're even talking about potentially getting rid of quarantine periods. Instead of going to quarantine and losing 2 weeks of school or work or whatever it might be, just test yourself daily, every single day. And if you can do that for the first 7 days and you remain negative, you're likely going to be, you'd be clear. Now, I would prefer to do that with a rapid molecular test if you're going to be, going out when you should otherwise be in quarantine. Slovakia did a massive rapid testing program. They didn't end up keeping it up as a frequent testing program, but over a 2-week period of time, on weekend 1 and weekend 2, both of those weekends, they tested around half of their entire country. Massively expensive, so they weren't able to do it because they didn't give the test to people at their homes. But what it meant was they were able to test and cull out huge numbers of infections from the population. And they saw a 60% decline in cases over just a couple of weeks. So that 60%, unfortunately, though, then they stopped the testing program and it bounced back. But that was pretty good evidence that this type of testing, along with other strategies, can really reduce cases, and that fit the theory perfectly.
Wow. Okay, Sarada has a follow-up.
Yes, thanks, Michael. So following up on this, so what's the take on following up a negative antigen test with a molecular test? I mean, I'm trying to say, is it mandatory or is it just a suggestion that you follow up a negative antigen test by a molecular test? Because in my opinion, this could get pretty confusing. Because, for example, I take a test, I'm a rapid test. I'm positive, it's straightforward. But if I'm negative, what do? Do I just go through this whole cycle of PCR testing, which is something we are, again, trying to avoid? And if that's the case, also, how do we report such a test? I mean, again, I can report a positive test, but if I'm negative with an antigen test, how do I report that? What's your opinion on this?
No, having to follow up an antigen test with a PCR test is just not, it just should not be the case. If we could do that, then we wouldn't need the rapid testing programs. We should not have a policy in the United States, and a lot of places do, because they're just, again, they're not keeping up with the science. We should not limit our antigen testing by requiring PCR to follow them up. That is a bad idea. It is also why I like to think of these tests as red light tests. They're adding an extra layer. They're not removing layers of protection. They're adding an extra layer. So there's no reason to, if you wouldn't require somebody to get a PCR test who otherwise isn't getting tested at all, which we don't require anyone to get a test, then why would we require somebody who's just adding one extra layer of protection to mandate that they also get a PCR test? That's faulty thinking by our government to create policy that requires that. And in general, it's starting to come down. But that has been sort of like the WHO has suggested that. So many places have suggested that any negative PCR, any negative antigen should be followed with a molecular test. And it is, it's one of the more ridiculous things I've seen from our government, and it's just been very, very frustrating to see them not keep up with the science in any real way.
That is very frustrating. Tim, okay, it seems like you have a comment and then a question.
The comment, Michael, I really enjoyed your talk, and I appreciate especially people talking about viral loads quantitatively, since the idea of positive doesn't really carry the information one needs. But lawyers don't really care about that. And so if you're going to convince an organization to accept a 20% false negative rate for the public good but personal harm, you're going to get your backside sued off. And I know a few organizations that would, I'm surprised that even universities have done it. In any event, the question I really wanted to ask was, there is extant public recommendations that you can be equally infectious after vaccination because the vaccine trials were done using the discovery of symptoms rather than the discovery of transmission or viral load. And my problem with that is I cannot imagine a vaccine mechanism that allows you to have a high viral load while preventing symptoms in 95% of the vaccinated people. Can you just explain where you think that kind of thinking comes from?
That kind of thinking comes from a huge array of people entering into the conversation, most of whom don't know what they're talking about. I mean, I know that came across what I just said as, didn't sound great. But my frustration with this pandemic has been, it's such a public issue, that everyone is affected by this pandemic. And so what that means, though, is that we have just a massive number of people entering into the conversation. The number of cancer researchers, who became serological epidemiologists overnight was astounding. And, then all of a sudden, everyone was surprised that antibodies waned, and it made front page news for a long time. But if you ask an immunologist, do antibodies wane after an exposure? Of course, always. You just have to look at what happens the first time a kid gets a vaccine. You get, by definition, you have plasmablasts. So I think that what your comment is absolutely correct. Of course, these vaccines are going to are going to help block transmission. By what exact amount, we don't know. Those should have been, again, we took a medical approach to thinking through our vaccine trials, and we didn't add in any metrics for public health. But of course, if we're stopping viral replication to a sufficient extent to stop any infectious or any symptomatic disease, then the immune response is also going to beat down those viruses from a transmission level. Is it 100%? Probably not. Where it falls on that gradient, we're not exactly sure, but it's going to be something. And so for anyone to suggest that we have no idea, at one point I want to write a textbook, or I want to write a book about essentially how, because we called this a novel virus, scientists across the world threw out everything we know about immunology and viruses and thought that we needed to rewrite it. But frankly, if you ask me, there is almost nothing interesting or novel about this virus. It's in almost all ways. There's a few interesting pieces that we've learned just because of how much studying the world has done of it. But the virus is the most prototypic textbook respiratory virus you could ever ask for. And so I think that what has led to so much confusion and so much bad policy is frankly because we never put the right people in the right room together. We asked virologists questions about immunity. We asked immunologists questions about epidemiology. We asked physicians to lead public health efforts. We have to come up with a better way to strategize who takes what part of each conversation in the future. I think that has been a massive problem here.
Just a quick follow-up. From my ignorant standpoint, I was quite surprised at what is apparently a large degree of asymptomatic transmission. Is that not unusual in other coronaviruses or just viruses in general?
No, I think it's very common. We see kids transmit viruses all the time. We usually think of them as childhood, largely asymptomatic transmission events are common. It's not very common in adults, but that's where we have to take a big step back and ask, why is it less common in adults and more common in kids? And it's, the one thing that is different about this virus is that we have adults who are actually getting infected. But by the time most people become adults, for any acute respiratory virus, they have seen it hundreds or thousands of times throughout their life. And so they're not going to transmit it. And the only time they will transmit it is if, for whatever reason, it breaks through their immune system and makes them really sick, because then it's actually clearly growing in them. But in general, I would say that we generally don't look as intensely for asymptomatic transmission. It's been so hard to find it in this pandemic, to really understand it, I should say, despite this being easily the most studied virus, ever. But that is why we're identifying it. And I would say that we see it all the time in kids who just replicate virus and are totally fine and don't appear to have many symptoms.
Thanks. Terrific talk.
All right, Wyatt, unmute yourself and ask.
Great. Hi, thank you. Thank you very much for the talk. I had two questions, quick questions, basically about changing perceptions. So the first is, I wonder if using a higher sensitivity antigen test, which could rival quantitative PCR, would be helpful in convincing people that that antigen tests could be broadly useful. So how much of it is that we're ingrained into using PCR-based tests in the laboratory as the only viable test? And then the kind of second part of changing people's perceptions is there, what's your opinion about the resistance to the at-home tests that they have to be done in the presence of a medical practitioner, that you have to, video chat in for a nurse to watch you spit into a vial, for example? Do you think that that's also a big limitation in broad surveillance testing?
Yeah, I think it's, I think there's a lot of money in this. And I think that there's very little reason for a company to, there's truly billions and billions of dollars. These companies that are making rapid tests, the moment you start you require each one to add an extra $20 on, there's enough demand right now that truly these companies are making billions, not like tens of millions. So there's, the FDA is going to authorize what the companies bring to them. This is where I think the Defense Productions Act and the president and Congress should have gotten involved much earlier to say, look, the way that the companies are going about building these tests is one thing, but should these all require medical prescriptions. Is there any reason why anyone needs a medical prescription anymore? No, absolutely not. But look at the millions and millions and millions of tests done in the United States. How many people saw a physician to get that test? Almost no one. How many physicians got paid or physician groups got paid to perform those tests? Every single test performed had a physician fee associated with it. These companies are making billions of dollars. Nobody's even talking about it, and that's a very hard train to stop. There's no good reason, there's no doubt in my mind that there are relationships between the e-medicine consult companies, these other testing labs that are setting these up. They're making, they have, $4 PCR test at the end of the day, but they're charging $120. Most of that goes to the physician's bill, which they're hiring the physicians, so I think this practice should have been stopped a long time ago. The FDA is only continuing to push it. I'm no longer sure that the FDA is not, conflicted financially, or some people in the FDA, because there's people. If you look at the pattern of what tests have been authorized for at-home use, and then you look at the pattern of where some of the leaders who are in charge of making those decisions have worked, you see a striking similarity. And so I've been, and I 6 months ago, I wouldn't have said that, and I certainly wouldn't have said it publicly. But at this point, I have looked at the data of so many of these testing companies and what they're trying to get authorized, and it is perfect, but then they're just getting rejection letters. So it's no longer making sense why certain tests are not getting authorized when they could be making them in literally the tens of millions per day for $2 a piece without a prescription. Meanwhile, we have, the same companies, really just the same two companies, Abbott and Quidel, getting authorization at this point for home use, for home prescription use. But, to more directly answer the question you asked, I think that there's no reason why these medical prescriptions should be required. I think the only reason is because we really need White House, executive branch type of intervention to say, hey, get rid of all the prescriptions. Like, they're just not needed in the middle of a pandemic. But in general, the government is extremely hesitant to meddle with the FDA decisions. But I think there's not an understanding of where the power lies. The FDA isn't really the ones necessarily pushing those decisions. It's the companies are pushing those decisions. The FDA can only approve or not approve the application that a company gives to them. So it really almost requires the White House to come in and not try to interfere with the FDA, but to come in and just use the Defense Production Act to say, hey, look, we're taking over this testing platform that you've built. We'll pay you a fair dollar for each test, but we're getting rid of all of the extraneous fees. That would be an appropriate public health response from our government. I do apologize. I just realized the time. I am supposed to be in another meeting right now.
Oh,
Was this scheduled to go for longer? I'm sorry.
no, it's just that we started late. But if you have to go, you have to go.
I can take another question.
One last question, please.
Yeah. Okay. Great. We've got
Ryan,
one.
go ahead, please.
Yep.
Oh, thanks for the great talk. Just quickly, and it's a very naive question. Would it be possible without FDA approval, sort of like I buy vitamins from Amazon? Is that something that, because if it was $2 a test, I mean, I would buy one, repeatedly. It doesn't seem like, is that something that's financially viable for companies, or is that even possible?
It's certainly financially viable. Many companies want to do it. In fact, Data Robot, which is a company that does data stuff, they just came out and suggested that they were going to do it. Unfortunately, the FDA is blocking that. We've tried for many months. That was the first question that I started asking back in April of last year. Can we do this as a surveillance mechanism? The FDA does not regulate surveillance tests. And so at that point, the FDA said, sure. I said, okay, great, let's start doing this. And then they said, but do the tests give results back to individuals? I said, yes. They said, oh, then it's a medical test. It has to go through us. So unfortunately, the FDA is sending cease and desist letters to any company that tries to do that. So there is potentially a way around it where if you said, Essentially the FDA says a laboratory can do it without an EUA as a surveillance test, but for any company, for these like lateral flow type of tests or any other rapid test, if you're giving a result back to an individual in any way, shape, or form, then that is by CMS definition regulated as a medical device. And that means that it falls under the FDA's purview, and the FDA has made it very clear that these tests cannot be distributed without an EUA. It gets increasingly complex and complicated, when you say, okay, the FDA is allowing these tests to be used off-label in asymptomatic people and in congregate settings, but with a prescription. And so the FDA's formal stance is, well, a single physician could write a prescription for 100,000 people. So, why do we have to make these off prescription? Which that tells me, that's one of the pieces that really makes me, very frustrated. If one physician is allowed to write a prescription for 100,000 people, the FDA is no longer in the practice of like improving health. It's in the practice of diluting medicine and what a prescription means. It's really it's astounding when you start digging into the decisions that are being made throughout this pandemic. None of them are commensurate with public health. It's been very sad to watch.
Thanks so much.
Wow. Okay. Well, Michael, that was great. And on that depressing note, we'll let you go.
Well, thank you.
Thank you, Mike.
Thank you all so much for joining, and always happy to do this again if it's ever of interest. So.
Oh, fantastic. We will have you back. Yeah. Okay. Thanks so much.
Sure. Take care.